Hello and welcome. I'm Dr. Ingvild Olsen, the Director for the Center for Substance Abuse Treatment here at SAMHSA. We are very pleased to be able to offer this webinar as you prepare your FY22 application for the SOAR grant program. As you know, the SOAR program aims to address the overdose epidemic by increasing access to treatment using FDA-approved medications for the treatment of opioid use disorder, reduce unmet treatment needs, and reduce overdose-related deaths through the provision of prevention, treatment, and recovery activities for opioid use disorder. Using SOAR funds, states and territories have implemented evidence-based practices using several effective and innovative approaches over the last several years. These approaches have resulted in positive outcomes, such as significant increases in client engagement, satisfaction, and retention in care, enhanced transitions for clients re-entering communities from criminal justice settings or other rehabilitative settings, increased naloxone availability, improved integration of wraparound recovery support services, successful family reunification and improved outcomes of child welfare involvement, and expanded access to on-demand treatment. While the SOAR grants have had positive impact across the country, as you are likely aware, we are continuing to lose too many lives to overdose. Provisional data from the CDC indicate that over 100,000, close to 105,000 now, people have lost their lives in the 12-month period that ended last October. We've also seen that some communities are being hit harder by overdoses compared to others. We also know that a proven strategy to reduce overdose deaths is education on and purchase and distribution of naloxone, the medication and a medication that reverses opioid-related overdoses to save lives. And through SOAR funding and other sources, states have been providing naloxone to their communities for some time. But the significant increase in fentanyl-driven overdose deaths that have been accelerated by the COVID-19 pandemic means we need to do more. And that is why, as part of the FY22 SOAR funding announcement, we've included a naloxone distribution and saturation plan that particularly pays attention to areas and communities with high rates of overdose mortality. To support you in fulfilling the plan and the requirements that are in the application, SAMHSA has partnered with the Opioid Response Network, ORN, to provide you free training modules. These modules include an overview of a modeling study to estimate the number of naloxone kits needed to reduce overdose risk, perspectives from urban and rural settings, and insights from the recovery community. We hope that these modules provide valuable information and insight as you develop your naloxone distribution and saturation plans. We so look forward to continuing to work with you and everyone in every community across the country to make sure that we are continuing to save lives of those impacted by this overdose crisis. Thank you.
Hi, I'm Mike Irvin. I'm a senior scientist in the BC Centre for Disease Control and at Simon Fraser University. And today I'm going to be discussing Learning Objective 1, which is about understanding how modeling can be used to estimate and understand naloxone distribution needs in order to avert overdose deaths. So in this section, I'm going to be describing a recent paper that I was a lead author on in the Lancet Public Health. And some of the motivation behind this paper was around trying to come up with a good estimate of how much naloxone is needed in order to reduce overdose death within states within the US. We started really sort of trying to focus on 10 different states that were representative of the different epidemiological characteristics, as well as representative of various aspects of individual naloxone programs. Using these 10 states and using these data obtained from these 10 states, we wanted to be able to estimate the number of kits that had been distributed, how these kits then had been utilized, in particular thinking about given a witnessed overdose, what is the probability, what is the likelihood that a naloxone kit is used during that overdose event. And then in addition, also thinking about how the totality of the naloxone kits being distributed and used impacts the total number of overdose deaths within that state. So taking these 10 states then, applying it to the data, we can provide an estimate from the modeling perspective to think about how this impacts the total number of overdose deaths experienced within that time period. But then we can apply the parameters, the data that we have utilized within that period to then think about how, if we had distributed more kits and more kits through various different sources, how these further distribution would further impact the number of witnessed overdoses which were intervened using naloxone, as well as thinking about the total number of further overdose deaths that could have been averted had there been a greater amount of naloxone that had been distributed. The final part of this then was to take these 10 model states with the parameters that we have derived from this modeling and then apply them across the entirety of the US to then provide a tool that can be used in order to understand how further distribution of naloxone will impact the number of overdose deaths within each setting. So just to give a slight primer on modeling in general then, I think given the last couple of years with the COVID-19 pandemic, has shown that mathematical modeling really is an increasingly important tool to assist with the monitoring and evaluation of public health programs. In particular, we can think of it as a framework that can allow us to pose certain questions given various aspects of what we understand about a system and its data. We can think about either looking backwards in time, thinking about what interventions had carried out, and trying to think about had an intervention looked different, how much further impact there may have been, and also thinking about potential future interventions. So thinking about ahead how things may change, and then in addition, how further different interventions may impact those changes. In particular, we adopted a modeling framework that was able to combine literature estimates, expert prior understanding, as well as data in a rigorous evidence synthesis formulation in order to be able to answer some of these questions. We considered then the different epidemiological characteristics of each state, and in particular we were thinking about composing each state into different epidemiological types. These types refer to the underlying risks associated with an overdose as well as the underlying overdose rates. We characterized it by those states which were dominated by fentanyl-related opioid overdoses, by heroin-related, and by prescription-related overdoses, and in particular combinations of the preceding three as well. We also then considered distribution types as well, so thinking about the many different models that exist for distribution of naloxone. In order to understand the benefits of each of these, we considered three different main types of access points. One was through community programs, so either distribution by programs or lay people in settings such as syringe service programs, thinking about provider prescribed, so this would be naloxone kits which are prescribed first by a provider, and then also thinking about pharmacy initiated, so kits that are provided through a pharmacist through some authorized mechanism. To give a brief summary of how we conducted this modeling, we considered for each state then its underlying population that would be at risk of an overdose. And these included factors such as individuals with opioid use disorder, those with co-prescriptions of, say, benzodiazepines, as well as other stimulant use, and those who would be at higher risk of an overdose, such as recently released from incarceration. This creates our total at-risk population. Then the impact of, for each given month, there is an underlying risk of overdose for this population, which is also impacted by the epidemiological characteristics of the state, as well as data that we are using to inform the underlying overdose rate from, for example, ambulance-attended overdoses. We then consider, of these overdoses, whether naloxone is used, and again using data from naloxone programs on its distribution and use to then derive of those overdoses how many were intervened using naloxone. This slide represents a very compact summary of our key results. So I'll just walk you through what this slide is representing. And so on the x-axis, we have the cumulative number of kits distributed in a given year per capita per 100,000 people. The points represent our model-based estimate within 2017. And so this was where, for the model states that we were considering, where the state was by the end of 2017 in terms of those kits that had been distributed. In the top row, we have the probability of naloxone use during a witnessed overdose. So we can see that there is a huge variation between the 10 model states that we considered within the fentanyl-dominated states. For example, in North Carolina, we see that the estimate of 2017 was at 60%, with this range of uncertainty. We can then also ask what were the number of deaths averted due to the distribution in 2017, and this is these points down here in the bottom row. Now, we also consider this counterfactual, where we ask, had there been more naloxone distributed through different channels, what would have been the larger impact due to its distribution? So for example, if we wanted to consider 80% of naloxone use, we would look at the top row on the graph here at the 80% mark, and then look to see where that line intersects, say for North Carolina, and then read off the value on the x-axis, so say that would be around 500 per 100,000 individuals, in order to reach a target of 80% of all witnessed overdoses. And similarly, we could then also read off what the number of deaths averted would be due to that further distribution of naloxone. We can also then consider this by distribution type as well. So this is a slightly different counterfactual scenario that we considered. So where we again estimated during 2017 where each of the model states were, which is given by these points here, and then looking at the y-axis with the probability of naloxone use during a witnessed overdose. We considered also these three different distribution channels, either through community-based THN, through standing order, or through prescription-based. We can see then with the community-based, the THN kits, that the relative increase in the number of kits is greater than if we say considered through pharmacies. And this is just due to our estimate, which suggests the further increase in the probability that a kit which is distributed, say, through a community program would have in terms of its use during a witnessed overdose event. It's more likely to be utilized, and therefore it has this larger impact in terms of its relative distribution compared with, say, a pharmacy program. Similarly, we can then look at the probability of naloxone use at a given level, and then by going along reading off from the line, we can see what the cumulative distribution of, say, community kits would be needed in order to reach a total target of, say, 80%. And finally, just to mention that we also have this interactive website tool where each of our model states that we had considered, as well as in addition all other states that we have applied these parameters and these understandings to, can be selected, and then from the available tools, this includes the counterfactual scenarios that I've just presented, so considering by the total amount of naloxone distributed through each channel, we can then look at each individual state and read off what the total probability of naloxone use would look like, as well as the total number of deaths averted may look like under different levels of cumulative naloxone distributed through different channels. And so that web address to go to is naloxoneneeded2save.org. and you'll find information on each state as well as for each of those counterfactual scenarios that I mentioned.
Hello everyone, I'm Alex Wally. I'm a professor of medicine at Boston University School of Medicine, an addiction specialist and primary care doctor at Boston Medical Center, and I am the medical director of the Bureau of Substance Addiction Services at the Massachusetts Department of Public Health. And I'm bringing Learning Objective 2, Apply Naloxone Distribution Lessons Learned from Massachusetts. I want to thank Mike, who was the lead author on this paper in Lancet Public Health. And I want to thank my co-author and Maya Dos-Simpkins for joining me in presenting today. And I also want to thank SAMHSA for shining a light on the issue of naloxone saturation. It's something we've been thinking about and working on in Massachusetts for some time, a goal that we have not reached, but there are lessons that we have learned along the way, and I want to share those with you today. So I'm going to tell you what I'm going to tell you up front. Some of it you may already know, but overdose is driven by an unsafe supply, and for us in Massachusetts, that comes down to fentanyl. Naloxone works when you get it to people who are most likely to witness an overdose. And there's a lot of ways to think about that, but it comes down, in my mind, to getting naloxone to people who use drugs. We have work to do to include and partner with people who use drugs, and that's true in a lot of ways. I'm going to focus to some degree on Black, Hispanic, and Indigenous people. And naloxone is a key piece in a broad and deep effort that we all need to take to try to address overdose. This is an advertisement from the Healing Communities Study, which is active in Massachusetts currently. It's an effort to really reduce the stigma around substance use, opioids, and encouraging the public to carry naloxone and making it clear that this is a multi-sector effort. So fentanyl is driving the surge in overdose deaths in the United States. Here is a screenshot from the National Vital Statistics System provisional drug overdose death counts showing the provisional number of drug overdose deaths by drug or drug class in the United States. And I've included here opioids, synthetic opioids excluding methadone, which is essentially fentanyl. That's that brown line. Next line is psychostimulants with abuse potential, which is essentially methamphetamine. The pink line is cocaine, and the blue line is heroin. And you can see here that the opioid overdose deaths in the United States are really tracking line by line with fentanyl. And it's the same in Massachusetts, but that connection is even closer, and that's because in Massachusetts we've had fentanyl around for quite a long time. So much so that we're really seeing a flattening in our overdose deaths between 2016 and 2021, with maybe a little edging up here in 2021, whereas the rest of the country has really seen an increase over this time. And that's really because, as you can see on this slide, we've had fentanyl in our drug supply for quite some time. The other thing to notice on this slide, and also I'll just click back to the previous slide, is that you're seeing a rise in both cocaine and also psychostimulant or methamphetamine related or involved overdose deaths. In Massachusetts, more prominently cocaine. And I'll get to that later on in the presentation. So fentanyl is really driving the overdose deaths. And fentanyl, by the way, is also one of the reasons why we have not reached saturation in Massachusetts. The more fentanyl that you have, the more naloxone you really need in order to saturate your community with naloxone that's needed. Part of that's because of how overdose works and how overdose response works. So what's the rationale for it? Well, it turns out that most people who use opioids do not use by themselves. There's someone else there. And if there's someone else there, then there's someone who can respond and rescue them with naloxone. We know the risk factors for an overdose. It includes mixing substances, using by yourself, and then getting your opioid from an unknown source, a source that potentially where it's contaminated or includes fentanyl in an unknown concentration. Another risk factor is abstinence, which really this is occurs for the people who are, say, incarcerated or people who go into drug treatment and are tapered or titrated off of their opioids. They leave those places with a lower opioid tolerance and a higher overdose risk than when they went in. And that's an issue that many people are not aware of. So together, these known risk factors are things that we can teach people. It's information we can give them to protect themselves. There's also, with opioid overdose, an opportunity window. Opioid overdoses take minutes to hours, and they're reversible with naloxone. So they take minutes to hours to evolve, and that allows us to have this opportunity window. Fentanyl is also an opioid, but it actually has the narrowest, I would argue, window of opportunity to respond. And so instead of an overdose evolving over minutes to hours, with fentanyl, that overdose evolves over seconds to minutes. And so we really need to have somebody right there with naloxone, ready to help somebody when they are using. That's a really important part of the package of education that needs to be offered along with naloxone. We know that bystanders are trainable to recognize and respond to overdoses, so equipping them with naloxone is important. And we also know that no matter how hard we try, there will always be fear of public safety, particularly for people in communities that have historically had conflicts or difficulty with law enforcement. And that includes people who use drugs. As long as we have drugs criminalized in the United States, then we're going to have some fear of public safety. Research shows that naloxone works. There has not been a randomized controlled trial of naloxone distribution in the community, but there have been many observational studies that together add up to a strong evidence base. And these include studies that have demonstrated the feasibility of distributing naloxone to multiple populations, studies that have shown that distributing naloxone and providing education can increase knowledge and skills. Studies have looked at whether there's any increase in drug use, and there is none, but rather an increase in accessing drug treatment among people who are trained with naloxone. There's also a reduction in overdose in communities. I'm going to show you more detail on what we've done in Massachusetts. And then it's been shown to be highly cost effective, where as far as a public health prevention intervention, we truly get our money's worth with naloxone. Honing in on Massachusetts, this is a study that we conducted. In Massachusetts, there was a surge in overdoses as far back as 2004 to 2006. You can see the map of Massachusetts with towns highlighted, shaded based on how many overdoses occurred in those towns. In response to this surging overdoses back then, naloxone was distributed through syringe service programs in Boston and Cambridge, first in 2006 and 2007, and then the state came in and funded the distribution of naloxone through the other syringe service programs in the state, and as well as HIV prevention programs, and then more programs in 2009. And so community naloxone distribution in Massachusetts has, from the beginning, really been focused on the community-based programs that seek interaction with people who use drugs. And in fact, naloxone distribution, before there was state support, was going on for several years there. But really, 2006 and 2007 is when state funding first came in. This was funded as a public health measure. And so that's all well and good, but there were several communities that did not have community naloxone distribution. And that's shown here with those yellow circles. And so the difference between what was happening with overdose rates in the communities with diamonds and compared to the communities that were circles allowed us to do a natural experiment, an observational study, and this is what we found. So in the communities that were the yellow circles, we considered their overdose rates to be 100%. So that's what the overdose rate you would have if you didn't have any intervention. The communities where there was a low amount of implementation of naloxone coverage per 100,000, so 1 to 100 people per 100,000, we saw a decrease in the overdose death rate in those communities by 27%. We saw in the communities where there was even greater naloxone coverage, up to 250 per 100,000, we saw an even greater decrease in the opioid overdose death rate. Now, if you remember Mike's modeling, he was calling for naloxone coverage rates of north of 500 up to 1,000 per 100,000 people, and that's really what is required for naloxone saturation. So we have achieved a lot of naloxone coverage, but again, we still have a ways to go. Naloxone distributed through community programs, as I was alluding to, really started with harm reduction programs, and this was really one of the first. The Chicago Recovery Alliance, led by Dan Bigg, he was distributing naloxone out of this van here well before it was on the radar of public health providers. From where Dan was in the late 1990s to where we are now, we now see naloxone has been mainstreamed and is really a core piece of the approach to opioid overdoses. It's endorsed, community distribution of naloxone is endorsed by the American Medical Association, the American Pharmacists Association, the National Drug Control Strategy since 2013, the American Society of Addiction Medicine, and the World Health Organization. And then a strong statement from the Surgeon General in April of 2018, really advising people to be equipped throughout communities, both people who use drugs as well as the people who care and love them. Okay, so how do we do this? How do we saturate communities with naloxone? And I really emphasized what we've done in Massachusetts from the outset, which is partnering with harm reduction providers to get naloxone to those at the highest risk for overdose. So the person who is most likely to see somebody who's overdosing and be able to rescue them is someone they are using drugs in front of or with. And in Massachusetts, we have enabled this through a community program standing order. So we have written a standing order since 2007 that has allowed the state funded programs to have naloxone available. And we have continually widened that order, adding more and more programs over time. And now we have quite a broad standing order that allows multiple programs and multiple disciplines to be able to equip themselves and distribute naloxone. Facilitating pharmacy distribution. So there's another type of standing order, which is a statewide pharmacy standing order that allows people to go into a pharmacy without a doctor or a nurse practitioner or physician's assistant prescription and obtain naloxone directly from the pharmacist. There are things that states can do in order to include insurance coverage, because naloxone picked up at the pharmacy is going to cost money, and people, for a preventive measure, are less likely to spend their own money on something that's preventive. And so it's important, if you can facilitate in your states insurance coverage, which we have in Massachusetts across multiple insurers. There's also engaging addiction treatment providers, federally qualified health centers, and emergency departments. These are key places where people who are at risk for overdose come in contact with, and you can offer them naloxone. And then first responders. So first responders were relatively early adopters of naloxone, first administering, and now in some communities actually leaving it behind after they respond to a 911 call. They'll leave it with the social network, the people who are living with the person who overdosed or with the person who overdosed themselves. So this shows only up through 2018 the volume of naloxone that was distributed in Massachusetts, taking sort of the three main naloxone streams and consolidating them here on one slide. So the blue section is the pharmacy standing order. The green is pharmacy non-standing order or prescription naloxone, and then the gold or yellow is community OE&D or overdose education naloxone distribution program naloxone. And you can see that the emphasis in Massachusetts has really been on this community naloxone because it's focused on people who use drugs and bystanders. Since this time, we've further expanded both community naloxone distribution as well as pharmacy naloxone distribution, and are well over 50,000 naloxone distribution events per year in Massachusetts, combining all streams. I want to highlight this publication that was in the MMWR from the CDC, or the Morbidity and Mortality Weekly Report in 2020, which was a repeat survey of nationwide of syringe service program based overdose education and naloxone distribution programs. And here it gives detail in this publication on the regional status of these syringe service programs. You can see in each of the regions they calculated a number of persons receiving naloxone per overdose death and a number of naloxone doses distributed per overdose deaths. These are two other metrics in addition to the number of naloxone kits per population that you could consider when you're thinking about measuring saturation of naloxone in your communities. This paper is a really nice reference to get a sense of the extent of naloxone distribution that's occurring nationwide from community-based syringe service programs. I'm going to talk now a little bit about prescribing and co-prescribing naloxone. So in December of 2018, the U.S. Department of Health and Human Services released a notice really to prescribers encouraging co-prescription of naloxone to people who are prescribed opioids, as well as people with underlying conditions that put them at risk for overdose, people who are prescribed benzodiazepines, and people who have a non-opioid substance use disorder, report excessive alcohol use, or a mental health disorder. They also encourage prescription to people at high risk of either experiencing or responding to an overdose. So that includes people who use opioids, people who use stimulants like methamphetamine and cocaine, people receiving treatment for opioid use disorder, and people who have a history of opioid misuse and have been recently in controlled settings where tolerance to opioids has been lost. So echoing my point about abstinence being a risk factor for overdose. A related step was the FDA in the summer of 2020 released the intention of requiring labeling on opioid use disorder medications and opioid pain medicines to co-prescribe naloxone. I want to talk a little bit about pharmacy naloxone. So there's been two recently published purchase trials that used very similar methodologies in two places. So a purchase trial is actually where people are sent into the pharmacy, they try to buy naloxone, and then they record that event, how it went. And Massachusetts had their purchase trial in 2018 to 2019. There, at that time, was a statewide pharmacy standing order that mandated stocking of naloxone in the pharmacy and mandated counseling. There were 200 randomly selected pharmacies, and they had both people who used drugs as well as people who did not use drugs who were sent in to each of these 200 pharmacies. And in 83%, there was a successful purchase of naloxone, and there was no difference, encouragingly, between the purchase success of people who use drugs versus bystanders. In the 17% where there wasn't purchase success or there was failure, the reasons were that 47% were not stocked, even though there was a mandate to stock. 25%, the cost of the naloxone was greater than $150, which was the limit set by the study. And then in 15% of those cases, there was a prescription required. So in 2020 and 2021, there was a very similar study done in West Virginia with some different outcomes. So a statewide pharmacy standing order that mandated counseling and reporting to the PMP. So it did not mandate stocking, by the way, but reporting. And so there were 200 randomly selected pharmacies again, only a 29% purchase success. Again, no difference between people who use drugs and other bystanders. The reasons for failure was that the 41% were not stocked. At 35%, there was a prescription required, and in 23%, there was an ID required, which is not a typical requirement in a pharmacy to pick up a non-controlled substance, but they were requiring that at substantially high rates in West Virginia. And so these are some of the things you can think about as you're trying to improve your saturation through pharmacy and standing orders in pharmacies. Another thing to consider is mandating co-prescribing. So this is a study from the JAMA Network Open that looked at Virginia and Vermont, which were the first two states to mandate co-prescribing with chronic opioid treatment. And you can see here, right when they mandated, they see a substantial surge in naloxone dispensing through pharmacies that spiked and then came down, but not at the level that it was at before. That is something that looks like it's a policy that could increase the distribution of naloxone pretty quickly. I'm not sure how we need more time to understand whether that's sustained or not. And we also need to keep in mind that this is going to people who are treated with chronic opioids, which earlier on in opioid overdose timeline were a substantial fraction of the people who had opioid overdose deaths. But actually in Massachusetts, it's a very small fraction at this point in time, and it's shrinking in many other states. So something to consider. Okay, so I want to turn to thinking about really this issue of saturation, because in Massachusetts we're doing lots of community naloxone distribution, we're doing lots of pharmacy naloxone distribution, and the question we're asking ourselves is, where do we turn now? Where do we really focus our naloxone distribution? And this study that we did using a statewide linked data set where we looked back at known and unknown touch points of the people who died. In this case, we used data from 2014. And what we found was half of overdose descendants actually touched our systems within the previous 12 months. So you can see, though, we looked at 8 touch points. 4 of them were pharmacy related. And you can see that on the left there, they included high doses of opioids, benzodiazepine co-prescription, having multiple prescribers or multiple pharmacies. And so if we looked at the people, the 1,300 people who died in 2014, and looked back on their last 12 months, about 19% of them had any opioid prescription touch point. And so, that's a little less than a fifth of the people had some involvement with the pharmacy. And so I think that is a rationale that we should be distributing naloxone at the pharmacy to people that are having these types of touch points. But when we looked at other, what we call critical encounter touch points, like opioid detox settings, or having a previous fatal overdose, or an injection-related infection, or being released from incarceration, together those critical touch points explained 37% of the people who would go on to die from an overdose. And so those are places that are as important or more important than the pharmacy. You can see that they there's a larger attribution of the population that is encountered at those touch points. Altogether, these 8 touch points that we know where we should be distributing naloxone, they only account for 50% of the people who died from an opioid-related overdose death. And that means we have to look further than our health systems where we're touching people. Part of that is, of course, the community distribution through syringe service programs. We also really need to look at the racial and ethnic dynamics in our overdose deaths. And so in Massachusetts, as white opioid deaths have decreased between 2016 and 2020, we've seen a substantial increase in deaths among our Black residents and our Hispanic residents. And so that is very eye-opening to us, and it really means that we need to do a better job of getting naloxone and other overdose prevention efforts to these communities where we're seeing now really concerning inequities in overdose. When a community is determining its naloxone strategy, the proportion and community burden of deaths due to overdose in specific subgroups, such as among Black people and minority ethnic groups, should be incorporated. So another piece of this is the contamination of cocaine, methamphetamine, and counterfeit prescription pills by fentanyl. There's an increasing, though unknown, number of people who do not have an opioid use disorder who are overdosing due to this contamination. So this is another place, probably another large group of the unknowns that we need to think about how we're going to engage if we're going to saturate the communities that need naloxone with naloxone. So this includes people without opioid tolerance who are unwittingly being exposed to fentanyl via non-opioids and overdosing. Fentanyl-related overdose is on the rise in people who use methamphetamine and cocaine. I have put here on this slide several case report or case series that lay out this phenomenon that are seen really across the country. The implication here is that overdose prevention efforts need to expand and innovate to focus on engaging people who use stimulants and counterfeit non-opioid prescription pills. I want to wrap up reminding folks of the Biden-Harris 2021 drug policy priorities, which for the first time shine a light and highlight the importance of racial equity, which I think is something we really need to keep in mind in our efforts to saturate our communities with naloxone, and specifically supports enhancing evidence-based harm reduction efforts, which I, again, am grateful to SAMHSA for supporting and having the opportunity here to talk to you about our experience in Massachusetts. So just one more time, our lessons learned: overdose is driven by an unsafe supply, especially fentanyl. Naloxone works when you get it to people who are most likely to witness an overdose. That means many times people who use drugs. And we have work to do to include and partner with people who use drugs, particularly Black, Hispanic, and Indigenous people, thinking about cocaine, methamphetamine, and counterfeit prescription pills. Lastly, naloxone is a key piece in a broader and deeper effort. Really appreciate the time. I'm again grateful to Mike and Maya for doing this with me. Thanks.
Good afternoon. Thank you so much for having me. I'm really appreciative of this opportunity to talk to you all about naloxone saturation. I'm going to talk about learning objective 3. But before I jump into that, I just wanted to talk for a brief second about some fascinating harm reduction history trivia. My colleague and research mentor, Dr. Wally, who you just heard from, is actually the first person in this entire country to issue a statewide standing order for naloxone distribution. So while I don't know if he talks about it that often, but I think it's kind of exciting to think about how much we utilize that strategy for enhancing naloxone access, and we're lucky enough to be on this webinar with him, who's the first person to do that. So now I'm going to talk about learning objective 3, which is to develop strategies and identify missed opportunities for optimizing the impact of naloxone distribution. So my name is Maya Doe-Simpkins. I'm the co-director of Remedy Alliance, which is a national naloxone buying club. And I just want to reiterate some of the things that my colleagues, Dr. Irvine and Dr. Wally, have talked about, and very explicitly distill it down. We talk about overdose education and naloxone distribution as an evidence-based intervention to prevent fatal opioid overdose. And this is important because this is one of the reasons that we're investing a lot of time and energy and resources into it. But the thing that I really want us to pay very close attention to, the evidence upon which it's based is from a model that has very specific key characteristics. So all of that evidence that says, yes, this works to prevent fatal overdose depends on a couple things. It depends on by whom, how much, and to whom. So by whom, almost exclusively, and especially in the earlier days of naloxone distribution, we're talking about by syringe service programs, and how much we're talking about needs-based, like as much as people ask for, so a lot. And to whom means people who use drugs and the people who are directly, regularly, and daily interacting with people who use drugs. And so the reason that this is important to draw those very specific highlight, attention to those very specific highlights of the model upon which the evidence is based, is that we have all kinds of really exciting and very creative innovation and adjustments to how naloxone gets out into our world. But we need to be very sure that if we want to achieve the goals that we know the evidence tells us naloxone distribution can achieve, we need to be sure that we have first fully saturated and fully taken care of the evidence upon which the models upon which the evidence is based, and then move into creative new innovations and adjustments. So I'm going to give you just a little bit of context for the direction from which I speak about this particular issue. Remedy Alliance for the People is a national naloxone buyers club. We largely focus on expanding access to cheap generic injectable naloxone, and this is particularly important because we have to have a lot of naloxone if we're going to end up with saturation, right? Remedy Alliance was established in 2012 as the Ocean Buyers Club, and it was established by, on the right-hand side here, you'll see a photo of Dan Bigg, who was the executive director of the organization that was the first ever in the world organized organization to come up with the idea of giving out naloxone to people who use drugs. And so Dan Bigg and our colleague Nab Dasgupta negotiated a really good deal for cheap generic injectable naloxone back in 2012 during a naloxone shortage then. And it's important to note this date because this was, first of all, 16 years after the very first ever OEND in the country. 16 years after that. At the same time, it was at a time when there were only 6 states in the entire country that had naloxone access laws. It was 5 years before any federal funds were available for purchasing naloxone. And it was also at a time when there were 0 branded naloxone products. So the reason this is important is that the entities that are part of the National Naloxone Buyers Club are the original kind of innovators of naloxone distribution in our communities. So as of Q1 of 2022, there are 150 organizations in 40 states that are part of Remedy Alliance. And in 2020, there were 1.3 million naloxone doses that were purchased for distribution. So I want to talk back a little bit more specific about the modeling study that Dr. Irvine went into great detail about. And one thing that I've talked with folks about as they're reading it and we're talking about it is they're like, what's up with Arizona? Arizona is the one place of the 10 states that were examined in the study that seemed to be getting close to or did a good job achieving saturation. So what's up with Arizona, right? So here's what's up with Arizona. One is that they had a very large grantee that was a syringe service program that got a considerable portion of the state's funds for providing naloxone out into the communities. And they were a syringe service program, which meant that they worked really explicitly and directly with people who use drugs. That same organization was allowed autonomous decision-making around product and what product they wanted to provide to different components of their statewide community. So that in touch with the community program was able to make those decisions about what products they wanted to use. The agency was also connected with other organizations that were working directly with people who use drugs. And their first priority was saturation among people who use drugs in their social network. And then second priorities were other ancillary populations that very well might be in a position to reverse an overdose, but perhaps not quite as often or as regularly as people who use drugs. This particular entity is the single largest non-governmental naloxone distribution program in the country. And over here on the right side, you see a photo of the organization doing street outreach in a parking lot. So now we talked about the example of how one great place that was able to get close to saturation, and I just want to talk about, without calling anybody out, in a de-identified example of a place that rolled out their naloxone distribution plan in a way that didn't have quite so much fidelity to the model upon which the evidence is based. And this is a place where there were historical tensions between overdose prevention advocates and public health systems. There had been advocates that were for many, many years really advocating to public health systems that they launch or expand overdose prevention efforts that didn't really come to much fruition. And so there were some tensions there. This is also a place where syringe service program legality varies by county. So literally, right across a county border would mean that what was legal on one side of the street, it became illegal on the other side of the street. Once federal funds for naloxone became available in 2017, those were the funds that were available in the state for purchasing and distribution of naloxone. And at that point, there were no state funds at all that were dedicated to the activity of naloxone distribution. The funds for distributing naloxone first went out to no drug coalitions and similar organizations, not syringe service programs or entities that work directly with people who use drugs. In this place, there were regional treatment administrators that were tasked with the responsibility of making funding decisions for naloxone distribution locally. And so some places that had existing good relationships with organizations that had relationships with people who use drugs capitalized on those. And then there were places where they did not have good or existing relationships with organizations that directly reached people who use drugs. And so there was wide geographic differences in how those funds got dispersed to purchase naloxone. In this place, the second largest overdose education and naloxone distribution program, which was a syringe service program, got $0 federal dollars or state funds for naloxone. And in 2020, that program that was completely unfunded with state or federal funds for naloxone, they distributed more than the entirety of the state's Narcan Direct naloxone distribution for the state. So this is the Narcan Direct naloxone distribution is the way that many programs access certain naloxone products for their programs. But it begs the question of, if this is the second largest OEND in the state, and they did more than the entirety of the model for the rest of the state, is this really the best use of public funds? Like, maybe we should have considered some different direction of funding, because if they were able to be the second largest, just imagine what they could do if they had some federal or state funding. I want to talk a little bit now about opportunities and enhancement of naloxone distribution with the aim of getting towards saturation. So one of the things that is really key and a time saver is to get to know a little bit more about harm reduction and OEND history. And there was a time when OEND did not exist separate from harm reduction programming and organizations. That's not quite so much the case now, but if we explore some of the history of harm reduction, we learn some of the program models that were extremely successful in certain areas or contexts or with certain populations, and it saves us time from reinventing the wheel. There's some great suggestions in the National Alliance of State and Territorial AIDS Directors recommendations that were issued in July 2021. Specifically, I'd like to talk about 5 components. One is to assess the needs of your local OEND to make sure that they have sufficient naloxone available. In 2021, there was a shortage of affordable naloxone, and it was unclear how well state and local health departments knew the availability of naloxone within their local organization. So 1, assess the needs. And 2, coordinate supply sharing. So often there are entities that have a naloxone supply that they're not moving quite quickly compared to a syringe service program or a harm reduction organization. And so if that's the case, moving naloxone supplies or coordinating the sharing of the naloxone products is a good way to ensure that there's not a disruption of naloxone distribution in the community. Another one that's really important and sometimes not thought of is assuring the flexibility of funds and the way that funds can be spent and the timeline in which funds must be spent. So if there's an opportunity to, allow an agency to push spending for naloxone purchasing a couple months here and there, that may be very strategic in terms of being able to access the most affordable naloxone that will maximize our saturation capacity. And this really dovetails into exploring the pros and cons of expensive products. There's absolutely a reasonable rationale for some of the more expensive branded products, and saturation indeed is defined by a certain volume. And so if there is a balancing of not attaining saturation in favor of the pros that certain expensive or branded products can offer, to really dig into thinking through what are the pros and cons of the expensive products. And then ultimately, and this is probably sort of the most fundamental and foundational component of achieving naloxone saturation, is to really ensure that our syringe service programs don't ever go without and do not ever need to ration. And so really prioritizing that those entities and those agencies have either the funding or the product to make sure that they don't ever have to say, I don't have quite enough, or is it okay if you take 1 kit instead of 2? And getting to know your local harm reduction organizations and syringe service programs. So some places have this long history and culture of great collaboration and well-known relationships between harm reduction and syringe service programs and their public health entities and state and municipal government. And other places don't have quite that history of that kind of collaboration. So get to know your local programs. And I would absolutely offer up that if you are unfamiliar with, or if you're not sure if you know all of your local programs, let us know. At Remedy Alliance, we're happy to sort of broker those relationships should it be necessary. So the other thing that I really wanted to discuss a bit is expanding services just beyond overdose education and naloxone distribution. And this is really supported in some of the more recent epidemiology that shows that people who use illicitly manufactured pills, or people who use stimulants, or people who use substances by routes other than injection are being missed by, are being missed at syringe service programs. And so in addition to being sure that it's not just naloxone distribution, that naloxone distribution includes syringe service programs, we need to consider what do we have available for people who snort or smoke their drugs, and what do we have available for people who have a substance that they're uncertain what it is. And so snorting, smoking supplies, drug checking services, and for sure we know that at this moment in time, purchasing smoking devices like pipes specifically is not a SAMHSA eligible purchase. Some more opportunities is to dig into secondary distribution. And this is something that we have in more recent years in the US really started to quantify, is that when we give people enough syringes to give out to their social network, we see a net benefit in reduction in infectious disease. And I think that we need to consider that same support of secondary distribution for naloxone. So people who ask for more naloxone for their community or their social network are organic caretakers. They're already poised and interested and invested in caretaking their community and social network. So we need to be sure, with naloxone saturation in mind, we need to be sure that those folks who we know are going to be giving naloxone out to folks that need it but aren't in front of us have enough of that product to make sure that their communities have it. And so the other thing that we see sometimes is that data collection can be a little bit onerous. And so we need to think about ways that we can reel in some of the ways that data collection and surveying and taking down people's specific details and information can be reduced, or at least opt out if the person doesn't have time or interest in providing that information. This also dovetails to the previous statement around secondary distribution. When we make those the data collection burden less onerous, then we also see an easier opportunity for expanding secondary distribution. So the other things that we can think about with other other opportunities to lower barriers is not making people sit around for minutes, hours. At times there's hours worth of training to walk away with a naloxone kit. And what we really want to be sure is that somebody who wants to come see us for 10 seconds, if they need to leave in 10 seconds, they don't leave without a naloxone kit. And we may want to spend more time with everybody. I always want to spend more time with everybody. But if folks are able to opt out of some of those longer time commitments, that's another strategy to be sure that we get more naloxone out into our communities. Another thing that we should really consider when we're focusing on naloxone saturation is to set a target for the percent of naloxone that goes out to people who use drugs specifically. So there's many different recipient audiences for naloxone, and one of my local county commissioners is a librarian, and she makes an extremely great case for why she wants some naloxone, and we're happy to give it to her. We need to be sure that when there's groups other than people who use drugs who want naloxone, that they have it, but not at the expense of giving out naloxone to people who use drugs. So really including in our strategies that when fundees and grantees are getting funds or product for preventing fatal overdoses, that there's a target that privileges people who use drugs. And then this is something that is increasingly become clear, and I think also addresses some of the points that Dr. Wally made about accessing people who don't historically access our existing services, and people in Black and Indigenous and people of color communities, is we need to look for non-traditional partnerships. We're not talking about the regular public health partnerships or the regular prevention partnerships, the regular health care provision partnerships, really looking into non-traditional partnerships, if you will. And these specifically should look towards groups that are developed to shield people from systemic harm. And then this is my final recommendation, which is to be kind to people who use drugs, because quite literally, given that nearly 90% of overdoses that are reversed in the field are reversed by people who use drugs on people who use drugs, it means that OEND success actually literally depends entirely on people who use drugs opting into this service of using naloxone on their peers and friends and social network. And so in this slide, I have a couple of photos of great, be nice to people who use drugs t-shirts and swag. Up in the upper left-hand corner, we have our colleagues from HIPS. On the most obvious front photo has a t-shirt that says, "Be nice to drug users." Over on the upper right-hand side, we have our colleague Alice, who runs the overdose prevention program at Prevention Point Pittsburgh, and her t-shirt says, "One person's junkie is another person's treasure." And then at the bottom, we have Julian Michael, who's wearing a shirt that says, "I love drug users." So opting in to preventing fatal overdoses is often something that people who use drugs emphatically and without question opt into. And at the same time, it is stressful and it can be painful and it can be traumatic. So we need to absolutely be kind to the people who are reversing the majority of overdoses in our country right now. So thank you so much for your time and attention.
Communities across the nation are mobilizing to address opioid and stimulant use and the overdose crisis. You can't overcome this alone, but we can, together, and we are. We are the Opioid Response Network, a coalition of 40 national organizations representing more than 2 million people. We serve all 50 states and 9 territories locally through our network of nearly 1,000 professionals working across prevention, treatment, and recovery. For state agencies, organizations big and small, and individuals working to address local needs, we bring training and education to bear on your efforts. We're here to help you help others through evidence-based support, all at no cost to you. For instance, the Opioid Response Network helped the Tribal College in New Mexico join forces with local organizations to develop a culturally appropriate prevention, treatment, and recovery training series for its students. In Rhode Island, we convened correction staff from 34 states to share how our program had reduced post-incarceration overdose deaths by more than 60% and supported them in their efforts to build similar programs in their home states. In West Virginia, we mobilized to help a clinic incorporate substance use disorder services into their practice, serving a faith-based community. We helped healthcare providers in South Dakota address barriers they face providing treatment services for their patients. We're here to help those on the front lines. So, what are your needs and how can we help? Visit the opioidresponsenetwork.org to learn more and to submit a request for support. The Opioid Response Network, funded by the Substance Abuse and Mental Health Services Administration.